I'm Kara Wegerman from Duke University Health System, and I'd like to briefly take you through our article, Challenges and Barriers in Hepatocellular Carcinoma Surveillance for Patients with Non-Alcoholic Fatty Liver Disease. My co-authors are Cynthia Moylan and Anna Mae Deal, both from Duke University Health System and the Durham VA Medical Center. We all know that non-alcoholic fatty liver disease is going to rise dramatically in prevalence and incidence, which parallels the rise in obesity in most of the world. Therefore, we know that there will be more cases of hepatocellular carcinoma to come, and we have yet to find an effective surveillance strategy. There are several main challenges and barriers that we highlight in this article. One is the scale of the epidemic itself. We think that about a quarter to a third of the US population has non-alcoholic fatty liver disease, and a good chunk of those people have advanced fibrosis. Therefore, getting all of those folks into surveillance is going to be a major challenge. We know it can be done, and it's being done with colon cancer screening, but we'll need large-scale efforts and a lot of community outreach to make it happen. Secondly, we don't have a good way to risk stratify patients with non-alcoholic fatty liver disease with regards to HCC risk. We know that patients with cirrhosis have the highest risk and that there is a non-zero but lower risk for patients with F2 and F3 fibrosis. Which of those patients should actually be entered into formal surveillance programs remains controversial. There are some markers such as PNPLA3 genotyping that have the potential to really add to our clinical risk stratification models, which basically include age, diabetes, smoking, alcohol use, and sex. The other thing is that the surveillance tools themselves have major limitations, particularly in this population. Currently, ultrasound plus or minus serum alpha-fetoprotein measurement is the standard of care for HCC surveillance. However, we know that ultrasound performs relatively poorly overall, and even more poorly in patients with obesity, which many of our non-alcoholic fatty liver disease patients are obese. So we're not sure if we can even detect small lesions in this population. A number of groups, including academic centers and industry partners, are coming up with blood-based tests and other non-invasive markers to detect early HCC, and these hold great potential for new surveillance strategies moving ahead. And finally, we talk about some of the major disparities in HCC surveillance. We know that patients in rural areas, patients with less access to subspecialty care, and patients of racial and ethnic minorities have lower rates of HCC surveillance. So we will need targeted interventions to reach these populations, some of whom have poorer outcomes and lower rates of liver transplantation for HCC. Hope you enjoy our article.